Start with roll call. And as I call your name, I think for this group, even though we've worked separately on the strategic plan, I don't think that publicly we've had introductions for our new members. Is that correct? Because we didn't have a February meeting. So please tell us a little bit about yourself to our two new members. So my name is Charles Macias. I'm the chair. Laura Friend.
My name is Laura Friend, and I have worked at Cook Children's for 4 years and been involved with an organization that I co-founded called Parent Heart Watch for 10 years, and very passionate about sudden cardiac arrests in children and giving them a voice with screening and AEDs, and I manage a program at Cook Children's called Project Adam that helps schools with their CPR AED emergency plans.
Tell them about the same.
And so we have a save right now. A 17-year-old that collapsed in Brownwood, Texas on Monday, May 5th, and it was his birthday. And he was saved with CPR. And not sure if there was an AED involved, and he woke up, tubes are out as of Friday. And as I was talking to our PR department yesterday to see if we could possibly get some media on this young man, I was getting him confused and wasn't aware with 3 other children that are in our hospital right now that are teenagers. We have 4 kids that have collapsed, and all have survived. And so that's great. And as far as Texas goes, for the state, we have, on April 24th, we lost a student in El Paso, cardiac arrest, 11-year-old playing PE. Pasadena ISD, we lost a student on the track May 3rd. And the following week, Deer Park ISD near Pasadena also, that student was saved. And we have a 24-year-old recruit at Lackland that collapsed and did not survive. So that is many kids in Texas in the last 2 weeks.
Thank you. Welcome to the committee. Next on our roll call, Bonnie Hartstein. Charles Jaquith.
Here.
Justin Hensley. Diana Kraus. Julie Lewis.
Present.
Aaron Lincoln.
Present.
Tell us about yourself.
Yeah, I'm one of the new committee members. I've been in EMS for 13 years now, and currently teach at Temple College, just north of here in Temple. Teach people to be paramedics.
And you're headed?
I am headed to medical school starting in July at A&M. I guess no Aggies in the room.
Thank you. Let's see, Sally Snow.
Present.
Sam Vance.
Here. Oh, I guess I have to talk. Okay.
You're up, buddy.
Okay, I'm Sam Vance. I am the EMS for Children Program Manager for the state of Texas. I've been here a little bit over 2 years. I also am the Secretary of the Pediatric Emergency Care Council of the National Association of State EMS Officials. Let's see, what else?
Where you came from before?
Prior to here, I was at St. Louis Children's Hospital as the pre-hospital outreach coordinator, where that role involved me in the EMS for Children programs in both the state of Missouri and Illinois.
Great, thank you. All right, and Vern Walker. Thank you. We only have one absent member. Perfect. So we have 3 committees without assigned liaisons, and we have 3 new members. Funny how that works. So the first liaison report is Air Medical. That was Jorge's. Laura, Aaron, Sam, which one of you would like to take that?
I can take it.
Dr. Macias, if they would, if someone would be willing to take over stroke, I can take aeromedical because I'm always in those committee meetings as well. So,
Anybody want stroke?
I'll take whatever.
Okay.
I'll volunteer for the medical directors.
So air medical is now Julie, and stroke is now Aaron, and medical directors is now Sam. So that means, Laura, you get the Rex. All right. So for those that had attended previous meetings, Vern, did you have any updates on EMS?
The majority of the work right now is just going through rule revisions and recommendations. It's kind of a continual process for them, but there's nothing specific to pediatrics at the moment. So I'll continue to watch and listen.
Thank you.
Dr. Macias, we could barely hear what he said.
Oh, microphone.
I just said that the EMS committee is mainly just going through the rule revisions and talking about that, and that we go across the state and gaining input on potential revisions and recommendations for revisions to the rules and regulations. Currently, there's nothing specifically pediatric related, so I'll just continue to listen and watch and see if there's anything that we need to act on.
Education, Charles.
The major thing that the Education Committee is working on right now is the community care project. We had a meeting down in Corpus Christi on April 10th that was in connection with the first state educators summit. They're looking at making the certain areas for the education-wise for the community paramedics to be a base floor, and then different sections will be broken down like diabetes, pediatrics, obesity, to put those into modules so that each area throughout the state could just pick and choose what they would need to work in their particular community.
Is there opportunity to input on the pediatrics modules?
There will be, yes.
Will you keep us updated on that?
We'll keep you updated.
Thank you. Injury prevention, Diana.
So they're actually meeting later today. I know they've had a summit meeting in Houston a couple weeks ago. I'm not real clear what all they're working on. Stuart neglected to give me an update. Who reports to me at Dell. So we're having discussions about that.
Okay, great. We'll look forward to a catch-up on last meeting plus
Yes.
this session at our next meeting. In the interim, if there's any pressing issues, you'll forward to the group, and I'll include it in the minutes as an addendum for
Okay.
public viewing.
I know they're very interested in the registry report that we're going to discuss about.
Perfect. All right, next is medical directors, which was Juan's. That is now Sam. So Sam, you'll catch us up on February and this sessions.
Yes.
Stroke.
the stroke committee will meet today at 2:30. They have several recommendations on their agenda. If you all would be willing to attend that at 2:30. Some of the initiatives that they're working on is looking at the triage criteria for transport bypass for stroke, and then education as well. That's all I have.
Okay. Anything specific to pediatrics?
Nothing.
Has, just by way of history, we have such a unique population, especially I think with our sickle cell disease population. Has there, in the last couple of years, ever been specific discussion with stroke on
Not
that
since
group?
I've been covering the stroke committee.
Okay. Thank you. Trauma systems. Sally.
Trauma Systems meets tomorrow afternoon at 2:30. They have several work groups that report at that committee meeting. None of them have specific issues related to pediatrics. They are also continuing to review the DSHS EMS and trauma system rules that have been in the works for a couple of years now. We anticipated having our consideration for pediatric transfer guideline on their agenda this time, but somehow Jory didn't get that message, and so it is not an agenda item, but she has asked me to be present to speak to that in general comments at the end of the meeting, so I'll be there tomorrow afternoon to do that.
Great, thank you. And that puts the RACs, which is now Laura. Just as an update, I think the most critical issues that were pediatric related in the prior meetings were related to SANE regulations. Anything that you're aware of currently? I know that you've just been assigned to it, but
Yeah. I'm not.
okay.
Maybe someone else is.
All right, and disaster planning.
So, here. That meeting met this morning in San Antonio, so I was not able to attend. I actually thought it was here, so showed up a little earlier and heard the TTAF discussion. But there has been some discussion on the listserv about infectious diseases and disaster, and a list developed. So I was, I'm going to follow up with them regarding what that discussion is specifically and how it might relate to pediatrics, which can be a disease population particularly affected in disasters and displaced person situations with infectious diseases. So more to follow.
Okay, and I think our only pressing issues from prior meetings was issues related to the AMBUS projects, isolates, and the other was pre-hospital screening of children. So if there's any follow-up on that as well.
Sounds good.
I had one other thing, Dr. Macias. The EMS for Children National Resource Center conducted a webinar on the checklist for pediatric domains and disaster preparedness. And they had that one in like April, and it filled up immediately. And I had asked Eric to put out a statewide alert that this webinar was taking place, and by that time it was completely sold out. But the National Resource Center has rescheduled another webinar for that material, and it's scheduled for the 18th of May. I believe it's 2 p.m. And I resent the link to register for that webinar to Eric, and he put it out again to the state, and several hospitals have registered for that. And if you need more information about that, give me a buzz and I'll let you know what the registration link is.
So Sally, some of the EMSC initiatives are permanently posted. I wonder if this is one. Is there a way that we could follow up to find out?
I know they're planning on archiving the webinar, and I was told by Diana in April, Diana Findia, that it would take about a month to do that, and I have not been told that it is archived. It is archived, and there will be CE available to watch that archived webinar. So it is on the NRC website, Sam said, the national. And so you can Google EMS for Children and find the National Resource Center and find that webinar.
Thank you. I know that was there was a lot of heavy lifting for EMSC to coordinate those activities, so I think that would be helpful for anybody who wants to view that. All right, so first agenda item is an update on the child fatality review teams and child abuse. I believe Amy Bailey could not be with us today, but there was one element that I just wanted to put on people's radar, and that is that the a quality improvement initiative based in Ohio has created a quality improvement collaborative, very similar to Solutions for Patient Safety for child abuse. And although the model is there in Ohio, Children's Hospital Association of Texas sent one representative. Two? Who was the second?
Kelly Liker from Bell Children.
Oh, wonderful. Okay. So two. So we should be hearing back. I've asked the Children's Hospital Association to provide a report for us on what initiatives, and then I will be meeting with, and actually I'll ask Kelly to meet as well, since I'm meeting with Dr. Dhanarama as well to follow up on that. And I think some of these initiatives really are about translating into actionable items rather than isolated demographics. So I think there's opportunity there. So be looking for that on the agenda. All right, item number 3, National Pediatric Readiness Project and an update on publications of the national survey. So JAMA Pediatrics, Journal of American Medical Association Pediatrics, recently published the National Pediatric Readiness Project survey about 4,000 hospitals with a pretty good response rate. Really talking about where pediatric readiness resides now, some improvement in the prior readiness scores, but the story itself was picked up by Wall Street Journal, Reuters, really receiving a lot of press. I think there's a lot more to come, and we'll link very integrally with some of our discussions, both in the Pediatric Facility Recognition Program, as well as the EMS State Partnership update. So be looking for some more on that. There's also, neglected to mention one thing, there is now a committee created within the American Academy of Pediatrics that will partner with efforts by the American College of Emergency Physicians as well as AAP under the section of emergency medicine there to address issues related to national pediatric readiness. So I think there'll be a lot of national activity, and I know that ENA is also engaged with that. Sally, do you have any? I don't have any updates on the ENA side.
I do. We had a board meeting in Washington, D.C. 2 weeks ago, and one of the things that came out of the stakeholders meeting that was held in Washington, D.C. on April 9th and 10th was that ENA would take the lead to develop pediatric champion teams in each state to help with hospital preparedness. And the ENA has agreed to fund a meeting with 4 or 5 pilot states that will be identified by the EMS for Children National Resource Center, so that we can develop a job description and some roles and responsibilities and duties for these state champion teams, because one of the things that we know is that the pediatric champion in the hospital is the thing that makes the most difference when it comes to hospitals being prepared to take care of kids. You can have all the equipment lists and all the competencies and policies and procedures you want, but unless you have a champion, you're not going to get as far with that preparedness response as you will if you have somebody at the champion. So we think that at a state level in each state, if we could identify an ENA member, a AAP member, an ASEP member, a rural health member, perhaps someone in an advanced practice role that's working in a rural health hospital, and family representation to make up those state level teams, that we could have resources for the hospitals in that state that they could go to for help with emergency preparedness in the hospital. So we're looking forward to that. So there'll be more to come on that soon.
And you said 4 to 5 pilot states, was that correct?
Yeah, that's the goal, is to have 4 or 5 pilot states identified that already have pretty strong champions in AAP, ENA, and ASEP, and pretty strong family representation to help write the job description and job duties for those state teams. And it could be the same people that are already involved in the EMS for Children Advisory Council. In some states, it may be someone different. So
wearing my chair of the national section of emergency medicine for AAP, I would encourage us to integrate Kate Remick as the subcommittee chair for NPRP, as well as a friend of this committee.
Absolutely.
Great. Thank you. All right. Next item is Pediatric Facility Recognition Program and National Facilities Recognition Program. Sam?
So we've presented to the council and numerous committees on our facility recognition program in the past, so I won't revisit that too much, but nationally, HRSA established performance measures in 2005 that were to assure the existence of a statewide, territorial, or regional system that recognizes hospitals that are capable of stabilizing or managing pediatric medical emergencies and trauma. And by 2017, all states and territories are required to have a system in place that recognizes these facilities. Many states refer to these as emergency departments accessible to pediatrics, to where all of our emergency departments are capable of taking care of kids, because we know from things like the Pediatric Readiness Project survey that the majority of kids are not treated at children's hospitals, they're treated in community facilities. There are currently 14 states that have facility recognition programs. They each have a variety of different ways that they're organized and governed, and we hope to make ours fit the state of Texas through our planning and development process with our stakeholders. There is currently a facility recognition toolkit that's been developed through EMS for Children and NASIMSO, and is currently being revised through HRSA for other states to use. Here in Texas, myself and Dr. Remick went to the Perinatal Advisory Council meeting back in February to present the facility recognition program to them and get their support and any guidance that they might be able to give us as we move forward. They were supportive of the idea. However, they're kind of busy with their program right at the moment. But I'll be following up with Dr. Toy, the chair of that council, to stay on their radar. We're currently working on a proposal to present to TTAF describing the program and the justification for it in Texas. Results from other states, including data that shows how it has benefited other states, budget considerations, and our next steps. Since TTAF currently performs the trauma surveys for level 3s and 4 facilities, to us it makes sense to collaborate with them to perform the pediatric facility surveys, since they already have a system in place without having to reinvent the wheel. And I should have that proposal ready for them soon. We're currently working on a timeline of targeted dates to shoot for to have goals completed, and we hope to put together a strategic planning meeting this fall, which we will be inviting numerous stakeholders. A lot of you are here in the room. That is pretty much where we're at with our facility recognition work group.
So, Sam, does it make sense for this fall meeting to coincide with, let's see, what are we, May, June, July, August, with our August meeting? Is that possible?
I think we could shoot for that. I think that's ambitious, but we can shoot for that. I was thinking more around November-ish, although with the EMS conference, that might be a conflict.
Do we know where the EMS conference is in November?
Dallas. It's in Dallas.
Okay. So working backwards from a 2017 deadline, that gives you roughly 18, 19, 20 months.
I'll go with your math.
Okay. All right. So we'll aim for fall, but if necessary, we'll look to our partners in Dallas to help host.
Yes. Also, just as to add to that, we did do 2 webinars back in April titled "Next Steps in Pediatric Readiness." Are we ready for facility recognition in Texas? And it kind of outlines what we're talking about here a lot better than just the 5-minute presentation here. That you're all welcome. It is on our website. So please visit our website and take a look at those.
Comment.
Yes, Christine Reeves from Heart of Texas, RAC in Waco, Trauma Service Area M. One of the things I'm wondering, I'm glad Colin is here, is when we begin to talk about recognition programs and survey processes, is that something that's going to need to go through a rulemaking process? I mean, since it says the state has to approve one by 2017?
Possibly. I think that's really a question for Jane.
So can we
I'll defer on that.
move that forward?
Yeah.
I mean, I can bring it up at rec chairs or
Sure.
something, but I'm thinking there's a step in there we may or may not be missing
Yeah.
before we go too far down the pipe. We want to make sure we do it correctly, so that it will go as it should. I mean, it's a wonderful program. We should do it. I'm very supportive. I just want to make sure we don't skip any steps.
It's a great point. Sam, can you, for our next meeting, actually prior to the meeting, can you send the verbiage of the metric that EMSC has set out? And Colin, can we, once we receive that, can we get that that feedback from Jane?
Yes.
You hesitated.
Let me speak with Jane. I think it's probably possible. So.
Okay. I'm thinking to the states that we know have the program, and since some of them have worked with professional societies, some have worked with the EMSC program. I'm not sure that they're all embedded in state regulation.
They're not.
It's voluntary in most states, so in fact, I think it's voluntary in every state, is it not?
Well, there are a couple states where it is written into their state statutes.
Okay.
Some are voluntary, some are not. There's just many different ways to set this up. Right now, and for future reference, here in Texas, it would be completely voluntary.
Yeah, that was my understanding. That's why I was taken a little aback by that question. So.
Well, I know that was the intent, but I think that the
Right.
comment regarding state recognition is an important point. So,
Okay.
is it possible to receive the state recognition and the program still be voluntary? And I don't know that really conflicts in
Let's
concept.
talk about it. Sure. Yeah.
Okay. I'm putting charges on here, Sam, to. All right. EMS for EMS for Children State Partnership. Sam and Dr. Shaw.
Dr. Shaw's in San Diego. The Society of Academic Emergency Medicine Conference. So, and can you all hear me? Is this working? Okay. In 2010 and 2011, the National EMS for Children program, along with Health Resources Services Administration, HRSA, developed an assessment of all of our EMS agencies to see how well we're doing in meeting certain performance measures. The 3 performance measures that were looked at or assessed was online medical direction, offline medical direction, and whether our agencies are carrying essential pediatric equipment and supplies. In 2013 and 14, they did a reassessment to see if we are doing any better, any worse, or have stayed the same. Nationwide, we had 48 states, the District of Columbia, and 5 U.S. territories participate. Nationwide, we had over 8,000 EMS agencies participate in this assessment for a nationwide response rate of 81%. Our cohort started in October of 2013 and ended on January 8th of 2014. Since we have so many EMS agencies within the state, they allowed us to do a sample survey of those agencies. We submitted the names of 1,067 EMS agencies and first responder organizations to the National EMSC Data Analysis Resource Center. They put all the names of those agencies into their computer, which randomly selected 459 services. Out of those 459, we had 326 that responded for a response rate of 71%. Out of all the states that responded, there was only one other state that surveyed more services, and that was Virginia, and they surveyed 498 agencies. From this map, this is representative of the ALS units from the ALS agencies that responded. As you can see, we did receive a pretty good sampling representative of the entire state. So, performance measure 71 has to do with online medical direction. Of those who attempted to contact online medical direction when treating a pediatric patient defined as 0 to 18 years old, how often was medical direction available to provide medical advice to your providers? As you can see from this, we are just slightly below the national average on that. But more importantly, if you look at our state data, to me, if you look at our comparison data from 2011 to 2014, our BLS agencies went from 71.5% to almost 89% of those agencies that now have online medical direction. Also, if you look at our ALS agencies that have online medical direction, we went from 81% to 86%. So that's good. Performance measure 72 has to do with offline medical direction. Basically, do these departments have pediatric protocols for the treatment of pediatric patients ages 0 to 18? And also asking how often are these protocols physically available in the vehicle and are available to providers during the calls. As you can see, we are right at or slightly above or below what the national average is. However, again, if you look at our comparison data 2011 to 14, our BLS agencies went up from 70% to 73% of those that have offline medical direction, and our ALS agencies also went up from 93% to 96.5%. So we know that pediatric protocols are available. The National EMS for Children program, as well as HRSA, are currently developing new performance measures. Those new performance measures will probably address the quality of the protocols. Basically, are we using evidence-based guidelines or not? And just as a reminder, we do have evidence-based guidelines that our director, Dr. Shaw, has helped produce with our Pediatric Protocol Resource Toolkit on our website. There are currently evidence-based guidelines developed for asthma, bronchiolitis, croup, air transportation of pre-hospital trauma patients, analgesia and trauma, pain management, seizure management, and external hemorrhage control. We also have evidence-based summaries that are available for C-spine stabilization, pediatric non-transport guidelines, non-traumatic shock, and post-resuscitation management.
Sam, can I interject for 1 second? So just
Yes.
By way of definition, evidence-based guideline is a comprehensive continuum of care document with systematic review of literature with recommendations. A protocol is evidence-informed, could be based off of a guideline, but creates an algorithm for care. And and an evidence summary is limited questions, correct?
Yes.
Okay,
and if I mixed all those terminologies up, I apologize.
No, I just want to make clear that we're not asking agencies to use evidence-based guidelines. We see creation of guidelines which are heavy investments, but off of those we can spin protocols which are not heavy investments.
Yes, and all of these evidence-based guidelines that I just mentioned are incorporated into the new NASEMSO model EMS guidelines that are available for agencies to use, and those are available on the NASEMSO website. So let's see. Performance measure 73 has to do with the percentage of nationally recommended pediatric equipment that is carried by our vehicles. As you can see, our BLS vehicles carry 90% of the recommended equipment, and our ALS vehicles carry 96% of the recommended equipment. And as you can see, from 2011 to 2014, we've pretty much stayed the same on that, but still carrying the majority of the equipment. As far as the least frequently carried equipment, we listed these as what we feel is the most important that our agency should be carrying, that they are not. As you can see, only 75% of our BLS vehicles are carrying the neonatal size mask for the AMBU bag. Why that is important is that if you receive a call for an imminent delivery on the side of the highway and you arrive and the baby is delivered and they're not breathing, how do you plan on ventilating the baby? Because I, for one, am not doing mouth-to-mouth on that. Just saying. The next frequently missing piece of equipment are suction catheters in the various sizes, then nasal airways in those sizes, and the pulse oximeter with pediatric probe. On our ALS vehicles, again, only 79% of them are carrying the neonatal mask for our AMBU bags. Those services, the intubation is part of their scope of practice. 80% are carrying the 2.5 millimeters size tubes. Almost 86% are carrying the 3.5 millimeter tube. Why that's important, as you all know, if the tube is too small, you'll get air leaks. If the tube's too big, it's not going to fit, and as you try jamming that in there, you're going to create trauma. Nasal airways in the following sizes as well. So in 2011 and in 2014, the most common reason for not carrying the recommended equipment listed was because the state does not require it, which that does have implications on the Rule 157 updates that are currently being done. Personally, I think this has direct implications on Rule 157 because the way it's currently written is not ensuring that the necessary equipment for our most vulnerable population is available on our ambulances, such as the neonatal mask for our AMBU bags. Therefore, the EMS for Children Advisory Committee feels there should be extra specificity included in the rule and not make it any more vague. Currently, the rule is not working by interpretation, so by making it more vague would not help. And I think this has direct implications not only on our neonatal and pediatric equipment, but also for adult equipment. If it's not listed, agencies are not going to carry it. Finally, I'd just like to thank all of our EMS agencies that participated in this. Thank you to all the RAC chairs, all the committees of GTAC, and the council that helped with the assessment. So, are there any questions from the committee or from the audience?
Do we have any point estimates, any sense of mortality or morbidity that arises from these gaps in equipment?
I don't know if there's been any studies on that have been done or not, to be honest.
Okay. Perhaps that's something we could follow up on. I think it's always, in the world of quality improvement and improvement science, putting a face on mortality and morbidity always makes it much more telling.
Right, and I agree. I think the only study I'm aware of off the top of my head is in Oregon. The University of Oregon is currently trying to produce a report in Oregon as far as trying to relate morbidity and mortality to their state's results.
Okay, thank you.
Dr. Macias, where would we capture that information in the state of Texas other than perhaps our trauma registry?
Yeah, I was challenged with that. I put a note to myself to investigate where those sources of data might be.
I don't know that that's in anybody's registry. I mean, it would be a PI issue at the hospital level or at the EMS level, but I don't know where we'd capture that. It'd be interesting to try to find out.
Okay, any questions for Sam, either from this group or from the audience?
Is the presentation available?
Sam, if you can send me the presentation when I submit the minutes for posting, I'll post the slides as an addendum.
Sure. Oh, and also just real quick, next week is EMS week, just to remind you all, and that Wednesday is always EMS for Children Day, so just throw that in there too. And we are doing a pediatric conference up in the Panhandle, up in Amarillo, on Wednesday to kind of help celebrate that. If you're able to make the trip up there, we'd love to have you. Oh, and we are, and I'm sorry, we also have our annual EMS for Children Crew of the Year Award. This year it is going to the Cy-Fair Volunteer Fire Department, members of Memorial Hermann Life Flight, and members of the Harris County Sheriff's Office. And we will be presenting that on Friday, May the 22nd at Cypress College, I believe is the name of it. Something like that. Help me out there, Catherine.
Yeah, Lone Star, Cy-Fair's campus.
Thank you.
All right. Next agenda item, special needs population updates. Bonnie, anything to report?
My last attempt to get more information regarding how any additional registries outside of STEER, there were not any that were through the parent-to-parent, et cetera. So STEER seems to be the kind of the current registry. Just to remind the group, that was the Texas-wide registry for special needs persons and mostly related to transportation needs for evacuation in a disaster. I think at the last report that Dee Dee Powell and her team did showed about a 10 to 15% pediatric enrollment, but so not a large percentage. I will follow up with them and see if they have a new report. I think they do that periodically. I did not see it on the agenda for the disaster meeting today.
When you say 10 to 15%, what is the denominator of pediatric patients eligible, or of all current enrollees?
Of all the people in the of all the enrollees, most of the enrollees then are adults.
Is it possible to get a metric as a percent of anticipated enrollment? How many do they actually enroll?
In terms of how many people? In terms of the entire
of eligible, right? Of all the pediatric eligible.
I'll ask the question of all the people. I don't know if anyone knows. You know, how would you get the denominator?
Yeah, I think it's probably estimates around populations. I think Dell might have that, Cook might have that for their populations, and TCH might have that for their populations.
Okay.
Just give us a better sense of
right whether we're getting whether we're anywhere near target. Maybe Diane.
Yeah.
Colin, were you going to interject something?
Did you have any more information that we were sort of doing this?
Okay. Next agenda item is update on pediatric transfer guidelines / interfacility transport review document.
Okay.
So.
The final draft of our considerations for pediatric transfer was posted on the GTAC website as an additional document. We had hoped to be on several subcommittee agendas this meeting to get feedback from that committee about the transfer considerations. I think we are very close to a final document and need just approval or endorsement from the subcommittees that we've asked to review it to be able to make it to GTAC as an official recommendation. Again, it is definitely a voluntary program. We want, and hence the name, considerations for pediatric transfer instead of guidelines, because we want people just to be able to use it and make it work for their particular area. It was never intended to mandate any kind of referral patterns. People already, or hospitals already have those, and we just wanted to make sure everybody had a standard set of conditions that would potentially need to be transferred to a higher level of care. Want to thank my work team, Dr. Remick from Dell Children's, Sam, Dr. Morber from Abilene, Julie Lewis, Christine Reeves, Justin Boyd, and Debbie Boudreau. Thank you guys for all the work you did on that, and I really think we have a fantastic product. We just need to get it vetted through those subcommittees.
So if my notes are correct, those subcommittees are trauma, disaster, medical directors, EMS, and air medical. I received the edits from medical directors, and those are integrated in
Correct.
the posted version.
Correct.
So we have only the 4 left, and we should be able to get those by the end of this session.
It depends on whether those people have actually seen because I've looked at all the agendas and it's not on anyone's agenda. So if I plan to go to all those committee meetings and at least get up at public comment and make sure everybody knows it's there.
So Colin, is there a way to, so I sent email requests to all those committee chairs plus a request to Phil. Is there a way to assure that if there's a declination to put it on the agenda, can it still go to GTAC, large GTAC? It's just a process question.
Yeah, I'm not sure. That's a good question. Let me get back to you.
Okay.
Yeah.
All right. If you could get back to me, this would affect whether we take it to Big GTAC on Friday.
Right.
Thank you. All right. Next agenda item, and thank you, Sally and the team, for some tremendous work with that. Trauma registry update. Chris Strucker.
Dr. Macias, members of the committee, thank you for this opportunity. Today we are going to fulfill a request this committee made back, I believe, in the November GTAC committee, but because this committee did not meet in February, we are now able to present it. There are 2 reports that the committee requested. One is a finalized pediatric summary report based on the data submitted to the registry, and a second report looking at data stratified by pediatric and non-pediatric facilities. These 2 reports are available in the guidebook, so I don't know exactly who has access to that guidebook, if the committee members have access, but they are also available on our website. So if you have a laptop or a smartphone, if you want to grab the reports, you can go to our website, dshs.state.us/injury, and in the GTAC presentations on our homepage, which Aaron is showing you. The top one, May 2015, is a link to both of these reports so you can follow through. In addition to these reports, I just wanted to make it known to the committee that we have now linked our crash data that we received from TxDOT to both our EMS registry data and to our hospital data. So if this committee is interested for future reports looking at pediatric-related pre-hospital and trauma care, that we can produce these reports. Dr. Leong, another one of my EPIs, sitting actually right here, is spearheading that initiative. So if you have any technical questions about that, she'll be more than happy to address those questions. As far as the presenters, I have 2 more of my EPIs. Erin, who's presented before, she's going to be going over a pediatric summary report, the general 2013 finalized report. And then our newest EPI, Casey, comes from the New York City Department of Health. She's a CSTE fellow in injury EPI, so we're excited to have her here. She's been with us for about 6 weeks. So, go ahead, guys.
All right, good morning. As Chris said, my name is Erin Cater. I'm an epidemiologist with the Trauma Registry. Today I'm going to go over our final pediatric report, a summary of 2013. As he said, it's on the website. If you want to pull it up, I hope you'll be able to see the graphics on here. And it's a little long, so I'm just going to hit the main points of it. But if there's something you want me to focus on, let me know. So the report's broken down into 3 sections, our 3 data components. First, we're going to talk about pediatric EMS runs, and then pediatric trauma hospitalizations, and then pediatric submersions. And for this report, we define pediatric as children less than 18 years old. So this will include everyone reported between 0 and 17 years old. For pediatric EMS runs, so by law, all EMS runs are reportable to us. This includes all medical and trauma runs. In 2013, we received 192,286 pediatric EMS reports, and this makes up just over 7% of all our EMS reports we received. Of these, just over half were male, 22% were white, about 57% were transported to a hospital, and about 16% of these runs were diverted. Over half these runs were medical runs, only 20% were trauma runs, 2% were medical trauma runs, and about 23% was unknown, or the reports did not indicate if it was a medical or trauma run. So this chart breaks down the runs by age and by sex. The males are shown on the left in green, and females in the blue on the right. The age groups are listed along the left-hand side. So overall, there were more medical runs than trauma runs. And this just shows the medical runs. There was 107,000 medical runs. There's a similar pattern for the males and the females, with less than 1-year-olds having the highest number of runs. Then it decreases, and then in teenagers it increases again up to age 17. This is the same chart, but for trauma runs only. There were only just under 38,000 trauma runs. The age pattern is different here compared to the medical runs. The highest age group is 17-year-olds. There's a little peak with 1-year-olds and lower in the middle ages, and then increase again to 17-year-olds. This table shows EMS runs by month. Medical runs are the dark blue bars. Trauma runs are the light blue bars. For medical runs, January had the most number of runs, decreasing slightly in the summer. And for trauma runs, so there's not a huge variance between months. That seems to be a little higher in the summer months. This chart shows EMS runs by time of day of the call. And there is a big difference between medical runs and trauma runs here. Medical runs are in the dark blue with the circles, and trauma runs are the light blue with the squares. For medical runs, the highest volume of calls is mid-morning, 10, 11, 12 o'clock. Whereas for trauma runs, there's a peak around 8 o'clock in the morning. And then again, it increases to around 5, 6 o'clock, which are the rush hour times. This table shows, for trauma runs only, the top 5 most commonly reported cause of injury by intent. The number 1 cause of injury are motor vehicle traffic accidents, and all of those were unintentional. Next is falls, followed by unspecified, then struck by, against, and then other specified causes. Among all the trauma runs, about 2/3 were associated with either motor vehicle traffic or fall. So the majority of runs were either motor vehicle traffic or fall related. And about 7% of all runs were assault or homicide. This table shows the median pre-hospital time for each of these top 5 causes of injury. This is the time from when the call was made to the patient was dropped off at the destination. So it ranges from about 36 to 45, with motor vehicle and traffic both having 39 as the median time in minutes, 39 minutes. Unspecified causes had the highest at 45, struck by, against 36.5, and then other specified at 42 minutes. This map shows by county the number of EMS runs we received for pediatric EMS runs. It's a little hard to see, but not surprisingly, the more populated counties are reporting the most number of runs. Next, we have our pediatric trauma hospitalizations. And so the reports we receive, the reportable conditions are traumatic brain injuries, all spinal cord injuries, and then other traumatic injuries that fall under certain diagnostic criteria and were either admitted to the hospital for more than 48 hours, died during the hospital, or were transferred in or out. So in 2013, we received 23,503 pediatric trauma hospitalization reports. Out of those, just under 300 were fatal. So this table again shows the pediatric hospitalizations broken down by age and sex. Again, males are on the left, females on the right, and the age groups are along the left axis. There were about 64% of the trauma hospitalizations were male overall. For males and females both, less than 1-year-olds had the most number of reports, decreases again, and then for males it increases back up to 17. Females it kind of levels off after age 8 or 9. Looking at hospitalizations by month, there appears to be a higher number reported March through October, through the spring and fall, and a little bit less during the winter. So this table looks at the reportable conditions as well as ISS categories. So for traumatic brain injuries only, We received 5,367 TBI reports. Of these, 158 were fatal. We received 73 spinal cord injuries, and 3 of those were fatal. There were 35 patients who had both a traumatic brain injury and a spinal cord injury. Of those, 11 were fatal, which had the highest fatality rate of the conditions at 31%. For other traumas, there were 17, just almost 18,000 non-fatal and 124 fatal. Looking at ISS categories, this ranges from 1 to 75, 1 being least severe, 75 being most severe. The bulk of the injuries had a lower ISS, but the bulk of the fatal injuries had a higher ISS. Those with an ISS from 25 to 75 have had a fatality rate of 23%, whereas those with an ISS of 1 to 9 had a fatality rate of less than 1%. This shows the median length of stay in the hospital by ISS. So the lower the ISS, the less time they spent in the hospital on average. For those with an ISS of 1 to 9, the median length of stay was 1 day, all the way up to those with an ISS of 25 to 75. The median length of stay was 7 days. This table shows the top 5 most reported cause of injury for these trauma hospitalizations. Falls was the #1 cause, followed by motor vehicle traffic, struck by against, transport other, and then fire burn. Most of these injuries were unintentional. You'll notice struck by against had 241 assaults and 35 self-inflicted injuries. This table looks at pediatric death, so only the fatal injuries by age. Traumatic brain injuries are shown in the red bars, and all the other injuries combined are shown in the yellow bars. So less than 1-year-olds had the most number of deaths, and the majority of these were traumatic brain injuries. For both traumatic brain injuries and all other injuries, the number decreases, and then once they hit 10, 11, 12, they start increasing again up to age 17. This map again shows the number of trauma hospitalizations by county, and again, the bigger counties are the ones where we receive the most reports. All right, and I'm gonna hand it over to Casey. The report on our website also has information on pediatric drownings, but that is all. All right, here you go, Casey.
Thank you. Hopefully this is good. This is good? Okay. Hi, good morning. My name is Casey Sile. I'm an epidemiologist also with the Injury, Epidemiology, and Surveillance Branch at DSHS. And in this report, we compare characteristics of pediatric trauma hospitalizations for pediatric-specific facilities versus non-pediatric specific facilities. For this report, we analyzed hospitalization records submitted to the Texas EMS and Trauma Registry in 2013. We focused on individuals under the age of 18, so again, ages 0 to 17 years. Our analyses are limited to records that were reported to the registry, which is a passive surveillance system. And the 2013 hospital data contains records reported as of December 2014. In 2013, 11 pediatric-specific facilities reported pediatric trauma hospitalizations, and 323 non-pediatric facilities reported hospitalizations. The Texas EMS and Trauma Registry is broken into 2 main components: EMS runs and trauma hospitalizations. The trauma hospitalizations, like Aaron said, includes TBIs, SCIs, submersions, as well as other traumas. So to start delving into the findings a bit, this first slide shows the age distribution of trauma hospitalizations by the facility type. On the left side is the pediatric-specific facilities. On the right side is the non-pediatric facilities. And you'll notice that the vast majority of trauma hospitalizations at the pediatric facilities are for patients between the ages of 0 and 17. Only 1% of the patients seen there are over the age of 18. In non-pediatric facilities, however, 87% of the trauma patients are ages 18 and older. 13% of their trauma hospitalizations are pediatric. So we wanted to know whether the age distribution varied among the pediatric hospitalization for these two facility types. So this is only looking at ages 0 through 17. And in both pediatric and non-pediatric facilities, about 1/3 of the pediatric trauma hospitalizations were patients between the ages of 0 and 4 years old. But non-pediatric facilities have a bigger proportion of hospitalizations between the ages of 15 through 17, 21% versus 7% at pediatric facilities. Next, we looked at the distribution of pediatric trauma hospitalizations by sex. The distribution is pretty much equivalent between the two facility types. About 64% of patients are males and about 36% of patients are females. This chart compares the race ethnicity breakdown of the trauma hospitalization cases for the two facility types. You'll notice overall the distributions look pretty similar. The pediatric facilities appear to have a little bit larger proportion of white non-Hispanic patients, and the non-pediatric facilities have a little bit larger proportion of Hispanic cases, but generally they're pretty similar. This table shows the leading causes of pediatric trauma hospitalizations by injury mechanism and intent. In pediatric facilities, 45% of trauma hospitalizations are caused by unintentional falls. In non-pediatric facilities, falls cause about 40% of the pediatric trauma cases. Unintentional motor vehicle traffic-related injuries are the next most frequent cause, followed by unintentional struck by against injuries. One apparent difference between the facility types is the proportion of cases caused by fire and burn-related injuries. This makes up about 6% of the cases in the non-pediatric facilities and 2% of the cases in the pediatric facilities. This slide is showing how the facility types compare in regards to injury severity score and length of stay. There's little difference in the ISS distribution for pediatric trauma hospitalizations. At both types of facilities, over 80% of the cases have an ISS between 1 and 9. The more severe injuries with scores of 10 or higher are less common for both. In regards to length of stay in the hospital, both facilities have a median length of stay of 2 days for pediatric trauma cases, and the range does vary. And also the proportion of missing data for certain elements varies by facility type. This slide gives a good example of that. The values are noted at the bottom of the slide with the asterisks. So both pediatric and non-pediatric facilities have about 6% of cases with an invalid length of stay. And about 3% of pediatric trauma hospitalizations in the pediatric facilities have an invalid ISS, and that's almost 12% invalid ISS at non-pediatric facilities. This table combines the two concepts to look at how the ISS is related to the length of stay. Regardless of the facility type, the median length of stay increases as the severity of the injury increases. That said, pediatric facilities have longer lengths of stay across each ISS level compared to the non-pediatric facilities. And this is especially noticeable for the most severe injuries. Pediatric facilities have a median length of stay of 7 days compared to 4 days at non-pediatric facilities. Next, we wanted to look at how many pediatric trauma cases were discharged to another inpatient facility. Very few pediatric trauma cases at the pediatric hospitals are discharged to other facilities, about 3%. Of those 3% that were discharged to another inpatient facility, about 1/3 went to another pediatric facility, and about 2/3 were transferred to a non-pediatric facility. And as you'll see in the chart here, the story is pretty different at the non-pediatric facilities. 31% of the pediatric trauma cases are discharged to another inpatient facility, and of those, about half went to a pediatric facility and about half went to a non-pediatric facility. Then we were wondering what the injury severity looked like among those cases that were transferred out. And the majority of the cases discharged to other inpatient facilities were those with an ISS between 1 and 9. We don't see too much difference between the two facility types here, and I'll also note that the numbers at the pediatric facilities are very small, so it's a little bit harder to make that comparison. We calculated the case fatality rate of pediatric trauma hospitalizations for each type of facility. Any record that specified death or expired in the ED disposition, hospital disposition, or condition on discharge was classified as a fatality. The case fatality rate at pediatric facilities was 0.9% compared to 1.4% at non-pediatric facilities. And finally, we compared the proportion of trauma hospitalizations that included a traumatic brain injury or a spinal cord injury. The proportions of both types of injuries were similar between the two facility types. About 22 to 23% of cases included a TBI, and about 0.5% of cases included an SCI. And this is where you can find information about the work from our branch, the link to our website, and the program's email address. And that's all. Thank you.
Thank you so much. I want to specifically thank you for including all of our requests for the sub-analyses and the specific topics. It's nice to be able to have that report tailored that way. So great job, Dr. Darker, and for your entire team. Diana, Diana is our liaison to this report, and you had some specific questions regarding the under 10 population.
Right. So we actually had a conversation yesterday, which was very enlightening. One of the things that stuck out in looking at all of this is that majority of children are cared for at non-pediatric facilities, which led the question, who is your denominator of what hospitals are you using? Through that discovery, we realized that Children's Memorial Hermann and University Health System are actually categorized as a non-pediatric facility in the state system. So any of those patients that were seen at either of those two facilities, which one's a level 1, the other one's a level 2, they're actually counted as a non-pediatric facility type, which probably makes a difference, would be my guess.
And you're correct on that. And because of our conversation yesterday, I had Casey run the numbers to see what proportion of records came from those two facilities that could be transferred over to the pediatric group. And so, Casey, do you have those numbers?
Yes. So to kind of clarify the issue here, those children's hospitals are kind of those children's hospitals basically report along with their larger entity hospitals, so there's no way to pull out which were they seen at the children's hospital or were they seen at the general.
They have the same
hospital.
number.
They're reporting all together.
They have the same facility number in their registry. That's the issue. They have the same facility number.
Right. And so if we assume that basically the number of the individuals who are between the ages of 0 and 17 and they're a trauma patient, that they likely went to the children's hospital. At the University Health Systems, it's a little bit over 1,000 in 2013, and at Memorial Hermann, it's close to 1,500. So that would change.
So just a clarification, when you say Memorial Hermann, that's to the system or to the single institution where the children's hospital is
That's to the
interconnected.
system, and that's the number of trauma hospitalizations between the ages of 0 and 17.
So one of the discoveries was that they have the same facility type number, and they're not separated out. And Chris, correct me if I'm wrong, they basically operate under one license number. Correct? Is that what we discovered yesterday?
So,
Can you repeat that? Yeah, sorry.
The reason they're set up that way is they operate under one facility number. Correct?
Correct. All the Memorial Hermann hospitals have one facility number?
No.
Sheila, help.
No. Several of the different Memorial Hospital systems have different ID numbers based on their locale. But in this case, this facility is situated in the same location, and so it comes under one registry number.
oh, so then it's not. So it's not an entire system reporting. It's
So
only.
correct, and that was the conversation I was just having back here, and I was going to
Okay.
say, it's not a system, it's specific to that facility.
So then that would be a reasonable assumption to say that that underage group went to the children's side. of
Correct,
that.
we can make that assumption, once again, it's an assumption, just like the assumption we made when we first compiled this report.
And I'm sorry. So how did that change the point estimate?
It's 2,500 patients.
Yes.
And
But
I
still,
believe that's about a third in that pediatric grouping.
The
So it's about-
non-pediatric.
In the pediatric grouping, I believe there's about 7,500 in this report. So if you add 2,500,
it brings up to
that's a third.
yeah,
So it brings it up to
10,000.
10,000.
So question.
I'm from Memorial Hermann Children's. So the problem is we are verified as a level 1 pediatric center and verified as a level 1 adult center. But in the state of Texas, the rules are written if you are connected and you're not a standalone, you have to go, you're designated as a level 1. So in our population at Children's Memorial Hermann, probably about 1,300 of those are going to be ours because our numbers are 15 and below. We send them to Children's, and age 16 and above go to our adult side.
So that was the other variable that we had a lengthy discussion about, is sort of understanding the distribution of trauma patients in our different racks. So I know in our rack, if you're 15 and above, you go to the adult level 1 facility. By EMS distribution, you can still have other patients show up, self-report. I believe in Dallas it's a little bit different.
It's 14, right, Lori?
Yeah, it's the same.
It's the same now.
Same in Fort Worth.
So that creates a difference. And so, what sort of the definition of what a pediatric patient is. And so for the ACS, pediatric patients defined as a child up to their 15th birthday or 14 and below. So when we look at these statewide reports, shouldn't we be looking at it the same way? Because that does make a difference. I mean, most of the children's hospitals, that's why you don't see a large population of 17 and 18-year-olds, or even some 16 at the children's hospitals, because EMS knows that they don't take them there. That also is representative when you talk about penetrating injuries or some of the other struck by against type of diagnosis.
Well, if we know the assumptions for ages and in joint facilities like that, I'm assuming that moving forward, that classification scheme can be used for an attribution to pediatric or non-pediatric facility.
Correct. Casey showed in one of the first couple set of slides the breakdown, and one of the breakdowns was greater than 15. So we can remove that from these reports and define the pediatric in this case as according to ACS's definition of pediatric, and then we can make these other assumptions. So we can include the correct cases into the correct groupings.
I think that only counts for trauma. So when you start looking at medical patients, I would probably say the majority of the children's hospital take till their 18th birthday. I know
Or
we
21.
have, or 21. I mean, we have congenital children that are young adults that we still see. So, for the medical cases, it's going to be different because we do operate differently in our racks, differently with medical type patients. The other comment as I was digesting this is, child abuse would probably be very helpful for us to pull out as a specific definition or diagnosis, because a lot of child abuse or anoxic or abusive head injury, sometimes you have very small ISS scores because they don't always have an injury. Whether that's
Codable injury.
It's codable injury. So that skews it. And I think as we look towards some of the opportunities we may have through this committee, and really and it goes back to the Ohio initiative and what they're doing with abuse, is having a standard definition or a standard approach that we could pull out children who were abused.
Lori's about to talk about E-codes.
Yeah. So Aaron and I have looked at that, and so one of the problems, if you want to try to pull the E-codes, you have to include assault, because what's happening, and that's one of my big initiatives, is to do some education related to this, is you have facilities that are using the assault E-code for child abuse as opposed to one of the child abuse E-codes. So to ensure, and we've looked at that, she's done reports for me, and we're continuing to keep doing it as more data comes in. That's what we talked about TTAP this morning. I want to look at it again in a few months. Is to ensure that we're using the right E-code. So if you do go down that path, Aaron's done it already, some data, you have to include the assault E-codes. And so that's what everybody needs to be aware of. When you're looking at abuse, if you're going to go to the state registry, you cannot just use the child abuse E-codes. You've got to include assault. And they'll use assault for somebody under 1, which we know that's an abusive, injury. So just keeping that in mind.
Okay. Well, thank you. If there are additional comments from the committee, if you can channel those through Diana, and then we'll communicate with Dr. Drucker. Thank you for that work. We've only got one agenda item addendum, and that is the EMSC state partnership. Sam, do you want to introduce?
Well, we had asked Mr. Joel Palfini, with the director of the state EMTF programs, to come and speak to us about what the pediatric capabilities are of the EMTFs. So, Joe, I'll turn it over to you.
Thank you. See if I can do this without causing too much trouble here. I don't know how much time you'd like me to.
So we have 8 minutes and 45 seconds, so you can have all of that.
7:45 is fine. Yeah. No problem. Well, I'll start out by saying thank you for having us here. Sorry I got here late. Disastrous meeting in San Antonio today, and the weather is horrible, so got here as quick as we could. What I really wanted to do is just come up and give you a very brief overview of the program, and this is less than 20 slides, and I can move through them pretty quickly. Just really talk about capabilities, strategies that we have for dealing with pediatrics, and then some planning assumptions I think that are important. I don't need to talk about Texas demographics. I think that's fine. Basically, the EMTF program started out of some discussions following the hurricane season of 2008. So if you remember, it was 50 or 60 some odd days of deployment in support of all the evacuations and the movements and that sort of thing. And we realized that organization was a bit of an issue. The state was doing a lot with a little bit of resources, and the regional advisory councils had done a lot of work to try to bring regional capability within their own areas, and we thought that there were some economies of scale there, and that this was the right place to do that, considering that the RACs were already working with the trauma folks and the EMS folks on a regular basis as far as data collection and a lot of other initiatives. So the response piece was just kind of the next obvious step. So what was sketched out literally on I believe it was a cocktail napkin at one of these discussions was a structure that at the time involved 4 components. We've added some since then, but those components are ambulance strike teams, which are a FEMA-defined resource of 5 ambulances with a strike team leader and common communications. So basically, it's a group of ambulances. We designed these medical ambulance buses, which you'll see on the top there. We followed some models from some other parts of the country in North Carolina and the DC area, but threw some of our own needs in there as well. So those are up to 20 passenger medical buses with oxygen and monitoring capability and that sort of thing to be able to move larger numbers of patients from point A to point B. And our mobile medical unit, which is essentially a mobile ER. It's not a field hospital. We don't want to stress any of the capabilities that are available in a hospital, but it really does serve the purpose of a mobile emergency room staffed with board-certified emergency medicine physicians, nurses from the local hospitals, techs, paramedics, that sort of thing. And then finally, our RN strike teams, which are groups that are basically going out to an impacted hospital after a local disaster where infrastructure wasn't necessarily affected. So things like plane crashes, train derailments, those sorts of things, where the hospital's still standing, they're just really busy. And we could really use some nurses that have skills that match our specialties, not just any nurse. Because we know that if you go to a large trauma center in an urban area like Dallas, the nurses that work in those trauma centers have a skill set that you won't find in a lot of other places. But you will find them in places like San Antonio or Austin or Houston and that sort of place. So if we could take those nurses and augment the nurses at the Dallas facility that may be impacted, that would be quite helpful. They very quickly realize that they share a lot of skills and that sort of thing and work well together. I kind of already talked about this. I wanted to just kind of jump ahead to some of the newer initiatives that are out there. First of all, last year and a half, we've integrated into our program, it's not this one, our medical incident support teams, which are basically there to serve as a liaison between local government and the state medical resources. So they tend to attach themselves to the state response and coordination structure in any impacted disaster region to assist with things like hospital visits and assessments and those sorts of things. We also started working this year on an infectious disease response capability, knowing this is, of course, all in the shadows of Ebola, and knowing that the state of Texas doesn't own ambulances, and that the ambulances that are going to be used are going to be local resources that are put on the state dime to do these jobs. So let's formalize that before we need to do it, and figure out what equipment and supplies they need and how to best train those guys and girls to get the job done. So that is a work in process right now.
Does that work partner with CDC?
It is strictly a state of Texas project right now. It does use CDC. The funding for the equipment supplies has come through a CDC grant, but there is no federal affiliation per se. It follows their guidelines to some extent. Very, very, very new project. Excuse me. So as far as the pediatric considerations, I'm sure this group is most interested in. The ambulance strike teams are ambulances that are on the road every day. So the ambulances that are picking up children and adults after car accidents, any medical conditions, these are the same ambulances. There's nothing, we don't add anything to them or take anything away from them except for an agreement to work for the state at time of deployment. So these ambulances that are typically looking at the EMSC programs and those sorts of things are the ones that are responding to these incidents. So that's, I think everybody's pretty familiar with how those work. As far as the ambulance buses go, we learned early on that these aren't necessarily the resources we want to be moving critical patients, because there's a lot of them. So managing many critical patients is a bad idea. These are really excellent tools for some of your greens and light yellows, and greens and blues, if you will, and your triage criteria. And they're fantastic tools for things like nursing homes. We have had some discussions with our ambulance operator group. So these buses are purchased most times with grant funding and then assigned to an ambulance agency to run them every day. And we pull them back in on disaster day because we gave you an ambulance and you think you owe us coming back in when we need you for a state mission. There has been some discussion about moving neonates. A lot of the teams that have their sleds and that kind of thing to move neonates in isolettes have been spending some time with these guys trying to figure out how to make that work, because it would be awful handy to throw 3 or 4 isolettes and neonatologists and neonatal ICU nurses and those sorts of folks into this bus to move people from point A to point B in mass, as opposed to trying to staff a number of different ambulances that are doing the same job. So again, work in progress. A lot of it has to do with safety concerns. How do we secure those isolettes, and how much more vibration and noise are we exposing these children to? But again, works in progress. And then the mobile medical unit, again, like I said before, this is a mobile emergency room. So there is an equipment cache that includes a great deal of pediatric supplies, and emergency room physicians on a daily basis are dealing with kids. So there is some, obviously, there's pediatric specific training going there, but they also have to be ready to deal with adults in any given disaster situation. So that's kind of as far as it goes. We don't have specific pediatric resources as far as personnel assigned to these, although my next slide, which is one of my last, is our RN strike teams. So these are probably one of the best resources on the pediatric side, in that we've identified specialties, emergency, trauma, intensive care, burns, that sort of thing, that we can use, that we can bring 5 nurses to bear on a problem. And some of those teams that we've identified have been pediatric teams. So if necessary, we can, through the memorandums of agreement that we have with the hospitals, we can mobilize and activate these nurses that have a pediatric specialty to assist other facilities and potentially augment that mobile medical unit if there is a substantial pediatric requirement in the field. We typically say these nurses aren't necessarily the ones that are the good campers. You know, they're not going to be the ones living in the tents and working in an austere environment like the mobile medical unit all the time. We say they usually come with their own teddy bear, not one to give the kids, one for themselves. You know, they're hopping on a jet with a teddy bear, a toothbrush, and a bag of scrubs and that sort of thing to go to work in a hospital facility. But certainly is probably one of the specialized tools that we can deploy on the pediatric side. And I believe, and then of course, like I said, the infectious disease program is very, very young and under construction. So that was as fast as I could do that. What questions can I answer for the committee?
Well, I think we're going to have to table questions, but number one, I applaud you for the integration of the pediatric interest, and if there's anything that this group can help inform or provide or connect you with, we want to be a resource as well. So thank you very much for your report.
And I've given my contact information to the committee as well, so please, we're always open to suggestions and support, and we can certainly tie a lot of those things in if necessary.
Great. Thank you so much. So we have 30 seconds left for any public questions, comments. Otherwise, this meeting is now adjourned. Thank you.